Good afternoon. Hi, Yannick. Thank you for joining us. This is the Scleroderma Forum, and you are the first to be interviewed for this.
Thanks very much for the invitation. It's a great pleasure. And of course, EULAR is a great opportunity to discuss more in depth about systemic sclerosis, the present and the future.
Exactly. So you are one of the first minds we wanted to pick, brains we wanted to pick for your opinion. And there were some topics that generated more discussion than others. There are so many and all are interesting, but some you were also particularly involved in first person, like the combination therapy. Finally, we start to have more than one drug. And for the people that don't know, Yannick and I had the honor to coordinate the last set of EULAR guidelines, or EULAR recommendation for treatment of systemic sclerosis. And we also attempted to sketch some algorithm for treatment. But combination therapy is really starting to become a topic of discussion. Now, there was a debate, and I don't know if you had the chance to follow it, and there was combination therapy for fibrosis. The background was that scleroderma ILD is complex and is thought to have different pathways contributing to that. And so that we start to have effectiveness by different clinical trials. We wonder whether a drug could work in combination. Of course, the debate evidence, there was no higher evidence, and the first was done harm, and that a shared decision-making with patients needed to be involved. Did you have the chance to be this debate? Do you have this debate with your colleagues?
Yeah, of course. Anytime we are now discussing clinical cases, because as you said, we have now more than a single drug that is available in that context. The limitation is that these drugs are usually positioned according to the main organ involvement, and we have the question of whether it can also have a role in some other organ involvement, or should we always combine drug in order to target more than a single organ? And multi-organ involvement is not uncommon in the scleroderma patients. And of course, and I think it was one of the key avenues we raised at the end of the recommendation. Combination therapy will be the future of the management of systemic sclerosis. And we have strong examples to support that. If you remember pulmonary arterial hypertension, few years ago, we were giving one drug, looking at the walking test and see whether the patient was improving or not. Now, the recommendation of all the societies is upfront combination therapy, because for a so severe disease, you do better if you combine 2 or 3 major dilators since the beginning. So the vessels is not the unique component of scleroderma, but it is showing us, I think, the direction.
Yeah, you're right, and I entirely agree. So and actually, the first big trial that led to the approval of nintedanib did show that the background mycophenolate was actually increasing the treatment effect on nintedanib, and vice versa. So that, I think, that really started the combination. On this note, you were the senior author on this poster that explored EUSTER. First of all, for the people in the audience, they don't know, Yannick and I are both past presidents of EUSTER, and we contributed a lot to try and improve what we know about scleroderma through EUSTER. We're still very active. So would you tell us about this study, how you conceived it? What do you think were the taking points?
Well, the idea came out just after the release of the recommendation, because we wanted to provide some scientific data about the reality of the use of combination therapy. Is it already ongoing in observational data? And as you can see, we built together with Davis Monferrano, Corrado Campochiaro, both very nice Italian young investigators, a study to compare upfront single therapy by rituximab or MMF versus the combination of the two. Of course, it's just the beginning, so you can see that I would say only 21 patients receiving upfront combination could be analyzed for the outcome after 12 months, which is, of course, smaller than MMF alone or rituximab alone. But the results are quite interesting because we may anticipate that these patients have a worse profile than the patients who are treated in the daily life, in the daily practice by monotherapy. And despite that, as you can see, we can see that the outcomes regarding the percentage of patients with a decrease of FVC higher than 5% is quite similar between the three arms. So probably the patients are enriched in the group of the combination, and even without this with these characteristics, we have similar outcomes after 12 months. In addition, if you look at another outcome measures, which is the MCID for FVC, you can see that the combination is doing slightly better. It's not significant, but it is showing a direction. I would say that we would have liked to have more data regarding safety, but it's not fully part of the database by now. We may work on this, but it shows the feasibility, a trend, and really a direction for future projects.
No, you're right. I entirely agree. I think the first time you explore two things together, the first concern, as you were saying in the debate, is not to harm. And this showed that at least there was no reported big red flag on the combination. So, and also for the way of administration, one is a tablet, one is a 6-monthly infusion. On this note, do you recall whether most of the infusions in the EULAR were 6 monthly? Because there are, for instance, in the Japan trial, the rituximab was given with a different dose.
Yeah, we did not have the details. This is clearly one of the limitations, but we may work on this and go back to the centers and clarify this.
But most people in Europe, they use it 6 monthly anyway.
Absolutely. The question, usually 2 infusions at the beginning, and I think for most of us, a single infusion at the time of the new treatment and the follow-up cycles for the patients.
Nice. I wonder who will ever fund this trial. This would be a very hard trial to fund, but no.
You know that there is a French-supported project. The first one was Ever ILD project. It was on NSIP, 6 months. So basket trial, in fact, looking at patients who never received MMF versus patients who also never received rituximab, and it was the combination versus MMF alone. And the study showed better outcome for patients receiving the combination. So it's NSIP, it's not purely scleroderma, but Ever ILD number 3 has just started, and it is focused only on SSc-ILD. And it is short term, it is 100 patients, but we will learn from that, of course, because I think in the practice, and Francesco, you are very well aware of the EULAR database, combination therapy is used more and more for rituximab, for MMF, but also for tocilizumab and so on.
Yeah, no, EULAR will tell us a lot, because a prospective study head-to-head funded international will be hard. So this would be a classic study when we have a lot of patients, we can do propensity matching for a better control. Now that the data used are much better and more complete than before. Nice. I think this is promising. And there was a lot more on attempt or combination, but this was the most robust study. Now, if we want to learn from rheumatoid, to switch gear, that of course historically is a couple of decades ahead of our gentle folk in Scleroderma. They've done two things, these people. First, they start to combine, but then they start to treat progressively earlier. And I wanted to discuss with you this other EULAR. By the way, for the people in the audience that don't know, EULAR had 12 oral presentations. So it's really showing how important is this. If you're interested in scleroderma and you see scleroderma patients, go and check out EULAR. You can become a member. See, I still work as a president, even if I'm a past president. All right, so here I will describe this because I was the senior author on this. What we've done is, Yannick is very aware. For the people in the audience, they don't know. A few years ago, now we published a study based on the Euster registry on the criteria of the VEDOS, the very early diagnosis of systemic sclerosis. So these are patients that have red flag signs of systemic sclerosis, including Raynaud capillaroscopy changes or Scleroderma antibodies or both, or they have puffy fingers. And we've shown historically, we published now 4 years ago, that 80% of these patients give them 5 years and they go on and fulfill criteria for scleroderma. But the question here was, okay, they fulfill criteria, but do they have a clinically significant manifestation of scleroderma? How many of these patients really will require any other treatment for things that are not Raynaud's? And so here we wanted to check the proportion of patients that started without fulfilling criteria and go on and present a clinically relevant manifestations, meaning they either had MRSS, that was not zero anymore, so they have some skin fibrosis, they have a decline in the RCO, a decline of FVC, or a new digital ulcers, or a synovitis. And we've seen that 226 patients, or more than 50%, had at least one clinical event over 26 months. So really, these are more data that show the very early diagnosis is a phase in systemic sclerosis that could be observed for future clinical outcome and could be potentially important to intervene. Now, there was a lot of comments on this data, and for instance, some of the antibodies, but you have been involved, Yannick, in the VEDOS since the very beginning. What do you think?
This study is really the second stage. The first one was, what does mean VEDOS? Do some of these patients develop really overt disease according to the classification criteria? And together with the colleagues from Firenze, Silvia Bellandorandon, Milano, Professor Matucci, yourself, and all the Euster people, it was demonstrated that these patients move from VEDOS toward another systemic sclerosis, and even we could say that they have some are already systemic sclerosis since the very beginning. But classification criteria, okay, it is interesting, it is important for research, it is important for many projects, but being physician, what we want to prevent is the major organ involvement in our patients, because this is conditioning the outcomes, disability, and sometimes the survival of our patients. So this is clearly the first study that is looking very carefully at the event that may occur in some domains that are critical for systemic sclerosis. Skin fibrosis, vasculopathy, joint involvement, all that is measurable. And as you can see, it is quite common in reality because a little more than 50% of the patients have developed some of these events. And this is opening really a new area in order to predict these events, but on top of this, to intervene in order to reduce the risk of these events. So this for me, this study is really pivotal in order to guide the future. And I think it is also fitting with the new thinking about autoimmune disease, pre-autoimmune disease. And Francesco, I'm sure you have been inspired by the pre-RA or the pre-diabetes data. Can you tell us which of these data have been the more supporting this concept for you?
Yeah, I think, yeah, you're right. I've been inspired by that. The pre-RA data just next door to me here. The diabetes was very inspiring because a regulator like FDA accepted an immunological intervention to prevent a disease, and that was the inspiration. But it's a situation very different from ours because it's a strong genetic predisposition. for a diagnosis that is done and has a very strong connotation once it happens in young adults. I was more inspired by the pre-array and trying to learn from their mistakes too, because there is a concept of benign autoimmunity, or okay, until this cause an erosion is really benign, which I think they are causing troubles because, for instance, when you and I have a patient with rheumatoid that responds to methotrexate or to abatacept for that matter, we don't say, very good, patient responded, we stop treatment. Whereas in these pre-array studies, they had the ambition of preventing rheumatoid arthritis by 12 months treatment, which is a bit against what we know for patients with rheumatoid. So I think the concept that needs to go through in the rheumatologist is that intervening very early is not a vaccine. It's not that you cure, you prevent the disease. You just intervene in a stage where the disease still has minimum impact, and so you give more life back to the people. But if you stop treatment, the disease will go on with their course. Don't you think so?
Oh, no, you're absolutely right. And I have another question or comment for you. We can see here complementary domains of systemic sclerosis: skin, vasculopathy, joint. If we want to move the field forward, we will have to think about composite score for progression of the disease. How do you envisage these next steps? You want to weight them? Do you want to combine them? Do you want to add some? What might be the methodology to clarify this?
Yeah, so you see, you and I, 5 years ago, did a nice graph where we put these two triangles that expand over time. So I think this is like a bottleneck. When you take patients at the beginning, you can take all patients and eventually will go in one direction of the fibrotic damage or in the other direction of the vascular damage. And so you can put these events now all together, and wherever they go, you can take that as progression of scleroderma. So I envisage that we could do a time to event, whatever this is. If they get skin fibrosis or if they get digital ulcers, yes, they will have different type of progression. But as far as we're concerned, from the VEDOS is still a progression. So intervening at this stage not only is good because it's very early, but because you'll be able to capture all patients and all future events. That's what I think we could do. There is so much more we need to learn, though. The role of antibodies, for instance, CTAP antitopoisomerase here was 2.6 hazard ratio for event, and but anticentromer too. So this was really the role of scleroderma specific antibodies in future outcomes. And we didn't have the number to see whether centromere was enriching more for DU than MRSS, but we know, we can guess that that's the case. As you say, it's the beginning, but it's exciting because it feels like a good beginning.
So no doubt that it will be very soon another matter of discussion.
Yeah, it will be. Stay tuned. We'll come back on that. Okay, guess what? We just have 10 minutes left. The time flies when you are in good company, they say in Italy. So there was one thing that we could not ignore. I call it a wave. It was the wave of B cell depletion, because it was CAR T, but now it's a bit more than CAR T. Look, these are just 5 titles. There were a few more. One was the first results on tolerability and efficacy of BMS CAR T. The other one was the effect of the CD3, CD19 T-cell engager blinatumomab in severe systemic sclerosis. And the other one was the RESET SSC, the clinical trial for autoleucel in systemic sclerosis. And the Beyond CAR T cells, B-cell targeting, 2 years on persisting CD9 CAR T cells and nintedanib clinical response data from Germany. I quickly summarize here the results. Perhaps for time we can go just in the red bit here, but people online, they can go in detail here and they can go also in the abstract. And so the first study was showing that in patients with severe refractory scleroderma, treatment with CAR-T with the BMS 986353 demonstrated a manageable safety and a robust CAR-T cell expansion with complete B-cell depletion and meaningful improvement in skin tightness and lung function. Now, I noted here that the patients, of course, this was not controlled. These were RNA pol 3 patients, so we need to consider that. But it shows feasibility. The second, that the T-cell engagers also had the same effect on B cells, so this can deplete better than our monoclonal antibody, and also changes in biological endpoints here of T-cell activation and differentiation in systemic sclerosis. So they went more on a biological angle. The third showed that this treatment did not have an unexpected safety signal in scleroderma. You know, people with lupus are a couple of years ahead, so showed similar, and they got observation up to 6 months. And then we have 2 years of persisting CAR-T and nintedanib. So a combination now, to go back to the beginning, on this new B-cell depletion and nintedanib. We can go back and forth through this, but altogether we cannot ignore that this is a new kid in the block in scleroderma. And I wanted just to see, where do you think this is going?
No, it's really a very exciting time because, you know, working on an autoimmune disease with specific autoantibodies, with clear data to support that we can stratify the patient according to the autoantibodies, with some data supporting maybe a pathogenic role of some of these autoantibodies. It's not fully established, but clearly we are in an area where autoimmunity is critical. And it's so brilliant because we started with rituximab, then we may position obinutuzumab, then we have T-cell engager, and then we have CD19 CAR T cells. So we have a kind of we have a kind of grading of how much you want to be aggressive on your B cells in your patient. And this is going to be challenging regarding inclusion criteria, risk-benefit ratio. So far, the data we have are supporting a good safety profile. Still, it's only clinical cases, so we may miss some of the data. Some of the data are very preliminary. Having said that, it's very stimulating because, of course, we all have in mind of our patients who are not doing well for skin, lung, muscles, joints. You start 1 biologic, 2 biologics, and then the clinical response is not there. Or we have some other patients, maybe earlier, but with really bad signals for the prognosis of these patients. And of course, this would be another strategy available to treat these patients. Having said that, we should not reproduce what was done for hematopoietic stem cell transplantation. We need randomized controlled trial, even with the limitation of the blindness of the investigators, which may be challenging, but we need scientific and robust data in order to inform the best our patient, because it will be a shared decision. If you start this kind of treatment, we know that some side effects have been reported in some other areas, but this will have to be shared with the patient. And in order to be able to inform the patient, we need to have clear views about the risk-benefit ratio.
No, I agree. Now, besides, yes, I entirely agree on the robust data, but even people convinced about bone marrow transplant, there are some centers that are limited because they have a poor engagement from hematology, for instance, right? So I think this, if this really becomes a treatment available, it's a gear shift in mentality. We cannot treat our patients by ourselves. We need to get the hematologist on.
Yeah, but we have also heard that the manufacturing is really improving. It's faster, it's easier, and then the delivery of the treatment is I think, well procedures, and we, for example, the T-cell engager, there is a high probability that in the next future, it will be done in the rheumatology unit.
Oh yeah,
So we have to learn, we have to teach the nurses, the physician, but probably it will come directly in our hands. I think, Francesco, another thing we learned from this nice event of EULAR and autoimmune disease is that we have put a lot on doing joint biopsies in the recent years in order to try to predict the future of the ARE patient. It seems that we will have to do some lymph nodes biopsy very soon to verify the effect of this kind of treatment, the level of depletion, the effect on the various population, and the repopulation in the future. So probably you've heard that many colleagues now using ultrasound are able to take some lymph nodes in order to evaluate the B-cell infiltrate of the lymph nodes. It will be part somehow of the evaluation of these treatments.
Yeah, no, yeah, it's new to me. I never done one. It will be interesting to see. People that do it said at the end it's not difficult. But I think we have another low-hanging fruit here is the autoantibodies. If the autoantibodies disappear, that is a clear biological response. So at that point, I'm very curious to see what happens in the future, because if the antibody appears again and these patients have improved, does it mean that these patients now are a new VEDOS, are a second generation VEDOS, right? That they have now a new antibody. Who knows the capillaroscopy if it gets back to early pattern? So we'll see. I think the question mark for me is this a rituximab that is deeper and so it works a bit better, or is really a reset because it wipes off so much like a bone marrow transplant does, that it corresponds to a reset? And this to me is addressed only with time. If 2 or 3 years people stay like in bone marrow transplant without treatment, then I would prioritize this. Otherwise, I'm not sure.
I think the organ for which we will require the more specific data is the lung and ILD, because even through clinical cases, skin seems to move. Of course, myositis is moving, arthritis is moving, some other inflammatory component, disease activity is carefully monitored in that patient. But I think we need more data regarding what is happening in the lung, regarding the reality of fibrosis versus inflammation, the combination of the two, and how much depleting heavily on B cells, even in the tissue, may really change the outcome of ILD. And this may help us also to stratify in the future our ILD population, because maybe we will discover that some aspects may respond while some other do not respond. And it might be helpful more globally, not only to treat the patient, but to understand the lung aspect and the interstitial lung involvement. So definitely it's a critical field to follow.
Yeah, I agree. And look at this, there is another endpoint here, which is serological remission and improvement of pulmonary fibrosis. It could be a new end. Anyway, good. Thank you, Yannick. This is, I really find myself aligned. It's an interesting time. Both we're expanding on the reset and on the very strong treatment on one side and on the combination in the middle, and we're going very early exploring how we could intervene there. So finally, the Scleroderma field is not just clinical observations, but is action. Perfect time for the forum. So, and you perfect guest for the first interview. Thank you ever so much, Yannick, for your time.
Thanks for the invitation.
Bye, guys. Stay tuned. Until next.
Bye-bye.